this is the 4th Advanced Pediatric Endocrine Symposium, which we are organizing. The first one in the form was actually started off in 2017. And since then, many of the faculty, all the guiders, everybody is the same. And we are continuing with the same team for quite a long time. It's been really a pleasure in that regards. Now, when we had initially, we were always thinking that pediatric endocrinology is a rare group of disorders, which are complicated, which are cumbersome in terms of workup and very expensive treatment. So people used to, in a way, shrug away from pediatric endocrinology, don't want to go into this field, and everybody was very scared, so to speak, about that. Now, when we thought about this, what we realized that there are 3 issues in any health problem: awareness, accessibility, and affordability. Now, everybody says these are not affordable, but we believe that awareness actually is the elephant in the house. And if we increase the awareness amongst the general public, amongst the physicians, we would be able to improvise the care. And this was the motto by which we established the pediatric endocrine group, and then we started the Growth Society working in that direction. Now, if you look at the pediatric endocrinology burden in India and the specialists who are available, what we see is that we would probably have a handful, maybe 100 will be the overall, maybe an overestimation also at the moment, but now with more fellows, the numbers will increase. So this still is a very, very small number for the burden of population for type 1 diabetes, growth hormone, thyroid, all those things. And pediatricians are approximately in much bigger numbers. So we need to really have a bridge in which things can improvise and connect between the two so that we can have a continual good quality care in everywhere. So currently pediatric endocrinology is focused and centered in few cities. Some cities like Bangalore will have maybe 20 people who are there, but then some whole states will not have people who are trained at all. So we need to have more wider exposure, and that's why it's very important on part of everybody. And it's responsibility of us pediatric endocrinologists, and ISPE has been working a lot in that to really spread the message of pediatric endocrinology. We have been doing a lot of programs right from 2011, and you can see many of the same people have been involved, and they have always been our inspirational force there. We started with our first program in 2011, and then since then there have been hundreds of programs which were done in terms of workshops, in terms of advanced courses, practical courses across the country, which we have been conducting. Now, this basically is the 3rd Advanced Pediatric Endocrinology Symposium. And from there, what we realize that if we keep on doing workshops, how much time can we spend? Like, it's not possible to do workshop everywhere. So we started off with social media in terms of YouTube platforms. And from there, a large number of people actually were able to access, and you don't need to be there all the time. They can access that. Then we started an on-site fellowship program, and we have got Chetan from the first batch, Neha from the second batch today, who are there. We until now had 11 fellows who are being under part of training. Then what we realized is that if you want to have a structured training, we need to have a web-based program. So we started with our MedEClasses platform, which provides a lot of information, started with books, and then to practically use that knowledge, mobile applications were developed. So we have got a lot of e-learning videos available on YouTube with huge number of views. This is something which is available covering entirety of pediatric endocrinology. We have got structured learning program under our learning.growsociety.in. We also offer a 2-year hybrid program for fellowship and a 1-year hybrid for diploma. We had got a lot of people who come to us every 6 months for a week. They learn the exam. So it's a very intense process. So we are going to have some of the announcements about the results of the fellowship program, the first one. We conduct a lot of online courses, pretty much 3 to 4 every month. So it's quite intense. We have got a number of publications which are there. And what we are going to launch today is the 2nd edition of our pediatric endocrinology protocols, which is a completely updated book about latest protocols for pediatricians, pediatric endocrinologists, and we'll be releasing this today. One major advantage we wanted to take was with regards to our application, because that will provide much easy access to use, because what you learn, if you don't use it immediately, you will forget and the errors will come in. And these applications were developed, and they are now become the most popular endocrinology application across the globe. And we have done a lot of publications regarding the growth interpreter, which allows practical interpretation of growth. We have got the obesity interpreter, which has been validated. We have got puberty interpreter, which allows interpretation of puberty, for thyroid, for DSD, and all of them have been presented and they are in publication in different places in that regards. Now, what we have done now is a very interesting thing, which is actually a combination of all that we have done. This is a bone age assisted interpretation of growth. So all the pediatrician would have to do is to put some basic data. It includes information like birth weight, sitting height. So all the rough things that we anyway write down and we measure, we just write the Tanner staging, we match it, we have the bone age interpretation. And as soon as this is done, it is using all the algorithms which are available. And based upon this algorithm, we will have a lot of information, data points will be available. So you will have specific charts, bone age interpretation, lot of parameters, and this will predict the likely diagnosis, most likely investigation. And we are validating this now. So this will be a very valuable tool for screening pediatric endocrine disorders. And hopefully, so this is how the result will look like. So you will have charts and you will have table which has got a lot of interpretation, and then we'll give you the final interpretation as to what is the likely diagnosis in that regards. We are coming up also with a personalized intelligent EMR, which is going to basically decide based upon specific conditions, give the inputs for every condition. And once you choose those conditions, you get the data, you will get an output which will guide in terms of evaluation, assessment. So only those which are relevant will come up on that drop-down menu. And based upon that, you will have a state-of-the-art evidence-based algorithm-driven approach which will come and analysis will come. This will provide information in the form of also a nutrition chart. So a 7-day meal plan will be there.
Diabetes, and although it is rare, but when you encounter neonatal diabetes, it is very, very difficult to manage that, especially when they present in newborn period, how we can start, how we can manage with insulin, and if transient form, how we can switch over to all the oral hypoglycemics, and how many times we should check this glucose and how we should give insulin. So let's see, Dr. Riddle will talk on that.
So good evening, everyone. So as Pradeep sir has said that neonatal diabetes is very, very rare. It accounts for 2 to 5% cases of total pediatric diabetes cases. And so this is the case I recently encountered. 2.5-month-old girl presented with the rapid breathing, not taking feeds well, and a failure to thrive. So the current weight was just 2.5 kg, same as birth weight. Sugar was very high on presentation. RBS was 550, acetone was 660, and pH was 6.9. So there is severe acidosis, ketosis, and hyperglycemia. So this is the DK. Sepsis was ruled out, but HbA1c was normal, 5.1. So my residents were like, ma'am, can this be diabetes, or this can be another hidden sepsis, or can this be any IEM? So I was like, no, this can be diabetes because presentation is DK, failure to thrive. There was history of polyuria, significant dehydration, and HbA1c is not the marker for diagnosis of diabetes, especially in newborn period, because major portion of hemoglobin is fetal hemoglobin, not the adult hemoglobin. So HbA1c can be normal or even low at the presentation. So I did C-peptide, which was significantly low at the RBS of 250. And child was managed well with the DKA protocol and then put on the insulin, subcutaneous insulin. GAID antibody was negative. And we did the genetic testing suggestive of ABCC8 genetic defect, and child was safely shifted on glibenclamide. So neonatal diabetes, as I discussed, it is very rare. All the diabetes diagnosed before 6 months of age is considered neonatal diabetes, so the onset can be delayed up to 1 year. And it is very rare. The prevalence is 1:90,000 to 1:120,000. Most cases are monogenic, have some genetic defect. 20% are transient and 80% are permanent cases, require lifelong intervention. The mode of inheritance can be autosomal dominant or recessive depending upon which genetic defect is there. But 70 to 90% cases are de novo. So you won't find any family history in such cases. So we'll quickly go through the physiology of the insulin synthesis and secretion. So we need pancreas, healthy pancreas for the insulin production. There are 3 cells in the pancreas, alpha, beta, and delta, from which beta cells are required for insulin synthesis and secretion. And in beta cells, whenever glucose value goes above the threshold, it will sensed by the beta cells. It enter into the cell via GLUT2 receptor. Then it is converted to the glucose 6-phosphate by glucokinase. Then this glucose 6-phosphate enter into the Krebs cycle, glycolysis, and this results in increase in ATP to ADP ratio. And this increased metabolic activity causes closure of the potassium ATP channel, and this won't allow potassium to come out of the cell and causes entry of the calcium inside the cell via calcium channel, resulting in depolarization of the cell membrane and release of the insulin from this granules. So this is the large study as we have discussed. The most common cause is ABCC8 and KCNJ11 in this cohort. INS was the second most common, and the most common syndromic cause of neonatal diabetes was Walcott-Relison syndrome. This was EIF2AK3 gene. So if there is defect in early genes like PDX1, GATA3 or NeuroD1, they are associated with some other system involvement as well. Plus they have exocrine pancreatic insufficiency. If there is genetic defect in this, they have syndromic presentation or they have isolated NDM require insulin lifelong. If there is defect in this insulin synthesis or secretory mechanism, they also require insulin. Some of the forms respond sulphonylurea. And if there is defective insulin receptor, then there is they are associated with insulin resistance syndrome. So broadly, etiology of the neonatal diabetes is divided into the two categories, either defect in insulin secretion or defect in insulin action. If insulin secretion is defective, they are also divided into the transient or permanent. As we have discussed, 20% cases are transient. They require intervention for a few weeks of the life. And permanent cases again divided into sulphonylurea responsive or require insulin. And insulin requiring cases are either isolated or syndromic ones. And defect in insulin action, that is because of the insulin receptor defect. So transient neonatal diabetes, as we have discussed, it is 20% of all cases of neonatal diabetes, where the insulin or the other hypoglycemic agent requirement is for few weeks of the life, that is for 12 to 14 weeks. 50 to 60% cases may recur at the time of puberty or later on, but some of the studies have discussed that the recurrence may be as early as 4 years also. Genetics is most common cause of the transient neonatal diabetes is 6q24 imprinting defect, followed by KCNJ11 or ABCC8 mutation, and followed by INS or some of the cases of HNF1 beta. They present with severe hyperglycemia, but without ketosis in the first week of life only. They have severe intrauterine growth restriction. And some of the cases have associated feature of macroglossia or umbilical hernia. So if these features are there, you can have clinical pointer to transient neonatal diabetes. Many of these cases respond to sulphonylurea. And at the time of remission, so that is around 2 to 3 months of life, they develop hypoglycemia, clinically significant hypoglycemia, and they require diagnosis as well as management for the few periods of time. And as we have discussed, many of these cases relapse during the puberty as like early onset type 2 diabetes. So the genetics of 6q24 defect is very interesting. So in people who don't have 6q24 defect, so every baby carries one chromosome from mother and one from the father. So here in 6q24, paternal chromosome is unmethylated and maternal chromosome is methylated. Sorry, paternal chromosome is methylated and maternal chromosome is non-methylated. So if there is loss of the methylation of the maternal chromosome, then both the chromosomes express these genes and causing neonatal diabetes, and this is transient cases. Second scenario is like both the copies of the chromosome, if baby acquired from the father and both are unmethylated one, and both of this scenario A and scenario B is random events occur during the early phase of pregnancy and chances of recurrence is very, very low. And the third scenario in which there is duplication of the paternal copy of chromosome, but mother remains same. So in this case, if the father carries the same duplication, then chance of recurrence in the second baby is 50%. Otherwise, all other defect have very few chance of recurrence. The another cause of neonatal diabetes, permanent cases of neonatal diabetes responds to sulphonylurea. And the most common cause is potassium ATP channel defect, that is KCNG11 or ABCC8. That is also this of this genetic defects. Some of the cases are transient neonatal diabetes, behave like transient neonatal diabetes. 90% cases of KCNG11 mutation are permanent, while 10% are transient. Like while in ABCC8 defect, 66% cases have transient neonatal diabetes. Their presentation is somewhat delayed as compared to transient 6q24 defect after 1 week of the life, and they generally present with the decay, as we have discussed in the first case. Their severity of the IUGR is less as compared to 6q24 defect, this indicating the lesser insulin deficiency during the intrauterine periods. And because this potassium ATP channel defect are also expressed in muscles and neurons, so they also present with the developmental delay or early onset epilepsy. All these cases, 90% of these cases respond to sulphonylurea. Their mode of inheritance can be autosomal dominant or recessive. And as we have discussed, 90% are de novo. They don't have any family history. Now, insulin requiring PNDM, permanent neonatal diabetes, isolated without any syndromic association. This most common cause after ABCC8 is insulin requiring most common is the INS gene, and which is required for conversion of pro-insulin to insulin. If this defect is heterozygous, then the misfolded protein is formed, and that will accumulate in the endoplasmic reticulum and eventually lead to the apoptosis of the beta cells and insulin defect. Their onset is little bit delayed, but generally they present before 6 months of age, but they can also present up to 1 year of the life. And second other common cause is the GCK. They are autosomal recessive, and parents have the fasting hyperglycemia because of the heterozygous GCK defect. Others are the 10% cases of the potassium ATP channel defect also not respond to sulphonylurea, and they require insulin. Syndromic form of the permanent neonatal diabetes, the common one, there are more than 17 genes are identified nowadays, and the mechanism of the diabetes is because of pancreatic egenesis or beta cell dysfunction or beta cell destruction. The most common one is the Walcott-Relison syndrome. It is associated with spondyloepiphyseal skeletal dysplasia and recurrent liver and renal dysfunction. APEX, which is X-linked disorder because of FOXP3 defect and associated with immune dysregulation, polyendocrinopathy and enteropathy. Fanconi-Bickel syndrome because of defect in GLUT2. So there is defective entry of the glucose from blood into the beta cells. And these are also associated with liver dysfunction and hypergalactosemia. Rogers syndrome because of defect in SLC19A2, and this is associated with thiamine responsive megaloblastic anemia and sensory neural hearing deafness. Others are the Wolfram syndrome because of defect in WFS1, where there is combination of diabetes insipidus, diabetes mellitus, and deafness. And Donough syndrome, that is because of the defect in insulin receptor, and they present with severe hyperglycemia and severe lipodystrophy because of poor linear adipose tissue and muscle tissue. Others are the HNF1B, these are the very rare causes associated with renal cyst, microcephaly, deafness. And all of these cases associated with pancreatic agenesis. So they have also associated exocrine pancreatic insufficiency. And all of these syndromic causes of neonatal diabetes require lifelong insulin. When to suspect neonatal diabetes? So any SGH child, if present with the hyperglycemia, you have to think this hyperglycemia or insulin deficiency may be the reason for his or her intrauterine growth restriction. Polyuria with dehydration, decay, as in infants or neonate, especially many of the IM also mimic like decay presentation. So we have to consider decay if the C peptide is very low. associated history of recurrent low, large volume fatty stool. So that suggests the exocrine pancreatic insufficiency. And if there is hyperglycemia, requires some form of intervention to control the blood sugar associated with these features like developmental delay, epilepsy, skeletal dysplasia, liver dysfunction or deafness that points towards the syndromic forms. So we have to think of permanent form of NDM in these cases. So diagnosis is somewhat tricky in neonatal cases because we require RBS that is more than 200. That should be persistent at least for 3 days, and that requires insulins to reduce the sugar value. Also, keep in mind the other causes of neonatal hyperglycemia because which are more common as compared to neonatal diabetes, and these are the preterm babies, parenterally if we are giving high glucose infusion, sepsis, and some of the drugs, especially steroids, dopamine, epinephrine, norepinephrine, are known to cause insulin resistance and hyperglycemia. So second point is to differentiate transient or permanent variety. So if the presentation is in very early, first 1 or 2 weeks of life, very severe IOGR, very severe hyperglycemia, but no ketoacidosis, associated features if are there like umbilical hernia, macroglossia or omphalocele that suggests the transient variety of neonatal diabetes. And permanent variety generally present later after 2 weeks of life. They generally present with decay and they have less severity of IOGR as compared to transient cases. And you may or may not find positive family history in permanent variety. They also have other features like syndromic features or exocrine pancreatic insufficiency. So which laboratory tests to perform? C-peptide should be done in each and every case. If it is low at the time of hyperglycemia, that suggests there is insulin deficiency or endogenous insulin production is low to control the sugar value. HbA1c, though it is not reliable to diagnose the neonatal diabetes, but its value if more than 6.5, it is diagnostic of the neonatal diabetes. GAID antibody should be done only if the age is more than 6 months, where we have to differentiate that this is early onset type 1 diabetes or this can be neonatal diabetes also. Fecal elastase to rule out the exocrine pancreatic insufficiency. Fasting blood sugar of parent should be done because this is the direct pointer to GCK defect. And as per the recent ISPET 2022 recommendation, genetic testing is must in each and every case of neonatal diabetes, even we are thinking of transient variety. So management is stabilization with the fluids and insulin. And if the child presented with the DKA, as per the DKA protocol, they are managed. Initially, IV insulin given at very, very low dose, 0.01 to 0.05 unit per kg per hour. And our goal is to keep the sugar between 100 to 200 and monitor the sugar very frequently. So the transient neonatal diabetes, if the genetic report suggestive that this is transient neonatal diabetes, then slow weaning of hypoglycemic agent should be done. Sugar monitoring after weaning and after remission, sugar should be monitored every 3 to 6 monthly because as we have discussed, there are some reports suggestive of early relapse of transient neonatal diabetes. And 6q24 defect are at high risk of hypoglycemia at around 6 to 18 months of age. So also sugar monitoring is required around this period to identify these cases of hypoglycemia. Now, after stabilization, after excluding the transient cases, and now we shift the patient to subcutaneous insulin. And the giving subcutaneous insulin in neonate is very, very challenging because they have very little subcutaneous fat, very small dose requirement, and they are more prone to develop hypoglycemia. So, which site to use, how much insulin is to go, how much dilution to do is very difficult. So better is to give insulin pump, that is continuous subcutaneous insulin infusion, where the basal insulin is set at the dose of 0.1 to 0.3 unit per kg per day. And even in the insulin pump, we have to dilute the insulin in the cannula. And goal is to keep the sugar between 100 to 200. when we are transitioning the patient from insulin to the sulphonylurea, because genetic report suggestive of the potassium ATP channel defect, so it should be done in patient setting. It should be the transition should be very gradual. Dose of the glibenclamide is 0.2 to 0.5 mg per kg per day, but in some of the cases we may have to give very higher dose, that is 2.3 mg per kg per day. Side effects of the sulphonylurea is very, very less. Only reported side effect is transient diarrhea and staining of the tooth. And we can give a trial of glibenclamide, even we are waiting for the genetic reports, because most of these cases of the neonatal diabetes are sulphonylurea responsive and potassium ATP channel defect. And studies have shown that as early as we start this glibenclamide, they can also improve the neurological symptom, especially in potassium ATP channel defects. Now we'll go through these two cases. 10-day-old boy. I encountered this case in last month only. Presented with the dehydration. Birth weight was 2.6 kg. Current weight of 1.7 kg. Born, the mother was preemie and child was on exclusive breastfeeding. Very severe acidosis. pH was 7. Bicarb was 3 only. Creatinine was 2.7, suggestive of pre-renal ARF. And RBS was in the range of 250 to 350. So since last 48 hours, the sugars were in this range. So treating neonatologists were very concerned, okay, this can be neonatal diabetes or this presentation can be DK or not. So what I did, the ketone was done. So ketone was normal. So this definitely hyperglycemia and acidosis was actually disproportionate. So not suggestive of DK to me. So I checked the IV fluid dextrose concentration and it was very high. GIR was going at the rate of 6 to 8. So initially we have shifted the child to dextrose-free fluid and within 24 hours sugars were normalized. So definitely before considering the diagnosis of neonatal diabetes, we should keep in mind this common causes of neonatal hyperglycemia. This is a 1-month-old boy presented with failure to thrive. Birth weight was 2.8, current weight 1.5, significant weight loss, family history of prior sibling loss. RBS was at the time of presentation was 450. There was acidosis, ketosis. So this is DK. Looks like diabetes and shifted to subcutaneous insulin. On subcutaneous insulin, there are high, very frequent hypoglycemia. And even before child was sent to me, there was trial of glibenclamide given, but child has not responded to glibenclamide. The dose requirement of insulin was very low, 0.1 to 0.2 unit per kg per day. Child has some eczema-like lesion on the skins. So that suggests some of the form of the permanent neonatal diabetes or some syndromic association. Genetics was sent. And reports suggestive of FOXP3 defects. So this is X-linked disorder. And this genetic report has prompted us to screen the other endocrinopathy at earlier age. And we can offer them an option of hematopoietic stem cell transplantation because it is the therapeutic modality for the FOXP3 defect. So definitely in current era, we should send all the patients of the neonatal diabetes. Genetic testing is must. Thank you.
I think thanks a lot, Riddhi, for the wonderful presentation. And we'll have inputs from Dr. Pradeep.
Very nice presentation, Dr. Riddhi. I think I wrote many questions, but you already covered all. Especially how we should switch over when the patient comes, you start with insulin, and now you came to know that this is sulphonylurea responsive neonatal diabetes. How we should switch over to practically to
sulphonylurea? First, whatever dose of insulin we are giving, reduce by 50% and start the sulphonylurea at the lower dose, 0.2 milligram per kilogram per day. And then gradually, once the sugars are stabilized, increase the dose of sulphonylurea and reduce the dose of insulin. So this will take around 2 to 3 days. So in first case which I have discussed, we took 3 days to switch from insulin to sulphonylurea. Inpatient.
So that has to be done inpatient,
yes,
not at home. Any other question from audience? Yes.
Before shifting to sulphonylureas, the sugars should be stabilized. So there should be no hyperglycemia on the basal bolus.
Obviously,
Or the-
because once we switch the sulphonylurea after getting genetic reports. So by the time, obviously, insulin dose is stabilized and sugars are also in the normal range.
So
So
it's
we
no
don't-
urgency. Yeah. So other
we-
thing that people try to do is that we empirically give a sulphonylurea trial, but only 40 to 50% will actually be responsive. So this is strongly discouraged. Now, genetic testing is easily available. Get it done till the time insulin is the main therapy. And maybe you get an insulin defect or some other defect in which insulin is required lifelong. So you continue that. But 50% chance, I would say, is there. More important probably is also to keep an eye about the transient form, which Riddhi said very importantly. So earlier onset, milder disease, lesser decay, normal birth weight, think of more of a transient diabetes in that regards.
Once we get the potassium ATP channel defect, most of the cases respond to sulphonylurea. So
They will take time
They-
because by the time your channels will actually start
so
acting,
here,
it will
in
take
that
time.
case, ma'am, the defect was different. So folks P3 defect require insulin. They won't respond to sulphonylurea. So that trial was given before achieving the report of genetic test.
And even in the potassium
So
ATP
that-
defect, your initial requirement may be very high,
Very high.
0.81, because by the time the potassium channels start acting, you need that dose. And once they start acting, the doses come down.